that there was a lot of appetite for learning deep in depth about a few things within the SRHR basket. And therefore, the Spotlight series, of course, is something that we did from last couple of years, where the spotlight was on all aspects of safe abortions, legality, research, and rights base in India. But this is the second episode of the spotlight. And so we started with the most important, one can say, issue, which is easily preventable, but yet causes, if not prevented, addressed early, causes devastation in a woman's life, and that being of cervical cancer. The first episode, precisely 3 weeks ago, highlighted the devastating impact of cervical cancer in India, emphasizing the HPV infection as the primary cause. The first method of primary prevention, of course, is HPV vaccine, but we mustn't forget that safer sexual practices are the most important aspect of preventing cervical cancer. So now, moving forward in the same fashion, we bring to you the second session around cervical cancer. And today's session, we have two speakers. The second webinar is going to focus, as Manisha said, on secondary prevention of cervical cancer. We are very happy to have Dr. Gitanjali Amin with us, who has been a long-time friend and support of FPA India, who has trained us, our doctors and also partners, for a very long time, easily 10 years, I think we have been associated. And she is a practicing gynecologist and obstetrician in Mumbai, a senior expert on colposcopy, cytology clinic of AMWI, Kama and Albles Hospital and Vasanta Memorial Cancer Trust. She has also been certified by FOXY and WHO, the master trainer for colposcopy and treatment with cryotherapy and LEAP. She has been a recipient of Golden Jubilee Award of AMI, the AMWI Mumbai. And Dr. Amin has been instrumental in the rollout and scale up of cervical cancer screening program in FPA India. And then the next speaker, Dr. Ratnamala Desai, who really needs no introduction to this group. Dr. Ratnamala Desai is the president of FPA India during her second tenure now. She is the principal of SDM College of Medical Science and Hospital in Dharwad, Karnataka. Also professor of OBGYN, Department of OBGYN, SDM College. President of FPI Dharwad branch since 2016. And trainer emeritus for the training of national level master trainers on insertion of subdermal contraceptive implants as recognized by the Government of India.
Today, I'm going to talk to you on secondary prevention of cervical cancer, mainly on WHO guidelines with regards to screen and treat, screen, triage, and treat. Cervical cancer is the leading cause of mortality among women, with an estimated rate of 604,000 women were diagnosed with cervical cancer every year globally, out of which 342,000 women died from this disease. In developing countries, including India, we do not have organized controls or cancer control program. Nevertheless, the Government of India coming out along with other national non-communicable diseases, and the cancer care is incorporated. Now in the near future, we may have a cancer control program which is organized and made implemented. As you all know, Zerusen is the great scientist who postulated the link between human papillomavirus and cervical cancer. After this, that is after 1983, we have seen because of the advanced molecular technology, it has revolutionized the cervical cancer control program, starting from prevention, primary prevention with HPV vaccination, secondary prevention through the variety of HPV tests which has used as a screening test, triage test, test of cure and even in the other follow-up care of cancer. So if you see this graph, you can see the prevalence of HPV infection is high in the early reproductive age group. The HPV infection is one of the sexually transmitted disease which occurs in the which usually is more prevalent in the acquires in the early sexual life. So the prevalence of it is more in the early sexual life. Usually with a good immunity, it clears up within 1 to 2 years. But more than 80% of the cases, the women gets cleared off with the HPV infection. But in 8 to 10% of the cases, it remain persist. The HPV persistence due to some insult or due to some other cofactor can develop cervical precancers, and if not treated, then lead on to cancer. So you can see the precancerous peak around 30 to 35 and the cancer peaks around 40 to 45, because if not treated, we get to see the precancerous and cancer cases at this age group. This shows us when we can prevent the cervical cancer by vaccinating the young adolescent girls and pick up the early precancerous and early precancers by screening with the appropriate test around the age of 35 and treat even if it is there, if it is detected in the advanced stage. The cervical cancer screening test, we have got battery of tests. So PAP, conventional cytology, it is a age-old test, conventional cytology-based screening with pap smear, which is developed by George Papanicolaou, has been the mainstay of cervical cancer prevention since 1950. Pap smear has been exceptionally accepted as a screening program without the efficacy being tested with randomized controlled trials, and it has proved its results. See, pap smear has got a moderate sensitivity with a very good specificity. Specificity, I meant to say that ability of the test to correctly identify the people without the disease. That means the high specificity means the positive test. If you get the positive pap test, that says that there is something in it. So it has got a positive. High specificity is the characteristic of pap smear, whereas HPV has got a high sensitivity, wherein the sensitivity is defined the ability of the test to correctly identify the patient with the disease. So high sensitivity means the patient, the lady with the negative test will not have a disease. She will be assured that she can go back to her regular life without undergoing any intervention. So liquid-based cytology is a modified form of this thing to improve the results of pap smears. The liquid-based cytology are recommended. In this, we collect the smear and put it in a container which contain this thing, and which is been centrifuged so that the debris have been cleared, and the smear will be, the stain smear will be clearer, the reading will be better, accuracy will be better. In this, you can do other tests also. Chlamydia, HPV testing can also be done and reduces the incidence of inadequate and the repeat smear by doing a liquid-based cytology. But as per this thing is concerned, it is not much of a improvement in the sensitivity or specificity. Next comes the HPV DNA test. It is an objective method, highly reproducible. Then it is not a subject dependent, more sensitive than cytology. That means if you have a high sensitivity, the negative, it has got a high negative predictive value. It should not be done in women less than 30 years of age because, as I told you, shown in the screen, the high prevalence of HPV without any precancerous lesion, if you detect, it's a overburden on the diagnostic system. Where HPV tests are available as part of the national program, HPV cell sampling offers an additional option to improve the cervical cancer screening coverage, especially to hard to cover remote areas, low resource countries, where these health workers can go house to house and explain to them how to collect the smear, and they can collect it, and these are received by this health worker and taken to the lab. So women may feel more comfortable taking their smear by themselves rather than going to see a health worker for cervical cancer screening. This is being implemented in the recent WHO guidelines. These are the following are the HPV various DNA tests used for cervical cancer screening, HPV DNA as well as RNA, mRNA amplification and genotyping test. One is the DNA based, that is the hybrid capture and care HPV test, which it is a highly sensitive test. And second is the PCR test, under which we have Cervista, Cobas, the Gene Expert, Abbott, and Papillochet. And more advanced tests like it is a biomarker studies, amplification of the E6 and E7 protein, and monoclonal antibodies test. Next, we are going into the simple visual screening test, VIA and VILI. It is a simple, non-invasive and inexpensive test wherein we use 5% glacial acetic acid, easy to learn, does not require the lab backup, is a real-time test. You apply and within a minute you get the result, and you can, if the patient is well counseled, and you can implement the subject the patient for the treatment for the screen positives. Even the non-physician can perform this procedure. The government of India has introduced VIA as the primary screening test about 5 years back. This is a screen VIA chart for the health worker to use it for the reference. VIA negatives, VIA positives, wherein you look for the dense acetowhite lesion touching the squamocolumnar junction, and the cancer cases. The VIA positive cases are further referred to for the further management of the cases, and the cancer cases are referred for the onco services. This is a VILI chart. If you do along with this thing, it is a very complementary test to the VIA, wherein the borderline cases can be it clears the doubt of VIA borderline cases. I usually like to do this VIA along with the VIA, though it is a VIA is a standalone test. Now we have got a VIA is a subjective test. You need the repeated training. The quality assurance is very much needed. So to improve the accuracy, we have got certain tools to improve the sensitivity of the test. That is, one is Magnascope, which has got a 5x magnification, and Smart Scope is there, and some mobile digital colposcope and gynecoloscope. These scopes, even the health worker or the nurses can use it. And nowadays it is AI incorporated. They have to just click the photos and send it to an expert, and they can interpret the findings. So the sensitivity and specificity of different cervical cancer screening tests based on studies conducted by IRC shows that HPV testing has got a highest sensitivity near 100% with a borderline specificity of 85%. VIA has got a low sensitivity with a specificity of 79%. Conventional PAP test, it varies from 50 to 70%, but specificity is 96%. And liquid-based cytology has got a same as that of a conventional. In summary, HPV-based testing demonstrates high sensitivity and specificity, making it a robust test for cervical cancer screening. So in brief, you all know about the colposcope. It is the triage test. It is a gatekeeper between the screen system and the decision of treatment. It triages the transformation zone, whether it is a small or big, whether it is a type 1 T-zone or type 2 T-zone or type 3 T-zone, depending on the size and location of the lesion. You plan the treatment method, and it also helps in the directing the biopsy from the worst affected area. And more importantly, it is an OPD procedure, does not require any anesthesia. Even the trained medical practitioner or the nurse also can perform this test in the low resource settings. Now we come to the WHO guidelines. The global strategy to accelerate the elimination of cervical cancer. It states that the vision is a world without cervical cancer. Threshold, it's a target to reach less than 4 cancer cases per 100,000 women in years. And goals are being 90% of the girls in the young adolescent girls should be vaccinated with HPV vaccinated by 15 years of age. 70% of the women screened with a high precision test at 35 and 45 years of age. And 90% of the women identified with the cervical disease, either precancerous or the cancers, receive treatment and care. We have got WHO screening guidelines, which is every 2 or 3 years they update depending on their research work. And in India, we have POXI GCPR guidelines for the Indian context. The main objective is to improve the national strategies for screening and treatment to prevent cervical cancer in all women, including women living with HIV and general population. So in this guideline, we recognize that most of the availability is the evidence on cervical cancer based on study population of cisgender women. So we also recognize the cisgender women, transgender, non-binary, and gender fluid and intersex individuals. So with the female reproductive system requiring cervical cancer care. So to be concise, in this we mention about women to referring all women who come for the cervical cancer prevention services. We have to provide them the equal care to all individuals, irrespective of the gender identity or its expression. So there are 14 recommendations are there. Salient ones I'm going to mention here. HPV DNA detection as a primary screening test rather than VIR cytology, both for the general and the women living with HIV. And when providing HPV DNA test, it says either sampling taken by the physician or with the self-collected samples among both the general population and women living with HIV is acceptable. And it also recommends starting regular cervical cancer screening at early as 30 years among the general population and in women with HIV at the age of 25. And WHO recommends after the age of 50, the screening can be stopped, provided you have 2 negative screening results consistent. They need not be undergo for the regular further. Priority should be given to screening women in the age group of 30 to 49 in the general population of women. When tools are available, the women with beyond age 50 who have not undergone the screening test can be screened and can be prioritized. So this is the algorithm of HPV DNA test for the screen and treat test. If it is positive, and use 5% acetic acid to delineate the criteria for ablative or the excisional treatment. Depending on the size and location of the lesion, you treat them with the ablation or excisional treatment. If the test is negative, send them for the routine screening and 5 other lesions. So follow them after the treatment. In case of VIA, if it is positive, if it is eligible for ablation, treat them with the ablation. If they are not, send them for the excisional treatment. If it is suspected of cancer, they has to be further evaluated and managed accordingly. And second is the screen, triage and treat approach. It is mainly introduced after this WHO the strategy to eliminate cervical cancer by 2030. It is mainly to accelerate the system and to lessen the burden on the diagnostic and the therapeutic system. the accuracy and the effectiveness of the cervical cancer program also will be better. In this, we have got 5 variables. They are mainly, you are screened with the HPV DNA cytology as the primary screening test, and followed by colposcopy, triage, and treatment. And the HPV DNA as a screening test, followed by triaging with the genotyping, or with a VIA, or with a colposcopy, or with a cytology. So here under HPV as a primary screening test, you triage either, depending on the which triage test is available, you subject them for that. This overall, it is a flow chart. You can see the screen, triage, and treat. And there are 2 tests used for the triaging system. One is HPV DNA and the cytology. And under HPV DNA, we have genotyping. That is the most 16 and 18, because most of the 80 to 90% of the HPV precancers are seen in 16 and 18. So you screen them and subject with the screen, both primary and screen test positive, subject them for the treatment. Or second triage test is VIA. VIA positive cases will go for the treatment. VIA negative will go for the follow-up after 2 years, because the primary screening test is positive, triage test is negative. They have to be followed after 2 years. And third is colposcopy is the triage, and fourth is cytology. And under cytology, you subject them depending on the availability. You can either go in for the HPV DNA or with the colposcopy. And even if it is ascus and below, you can do a HPV DNA, wherein in case if it is HPV is positive, then you can subject them for the colposcopy. If HPV DNA is negative, then you can send them for the screening after 2 years. If it is in the positive cases, colposcopy, depending on the type of lesion, you can subject them for the treatment. The treated cases has to be followed up with an appropriate HPV DNA test at 12 months. What we have covered today, what our goal is to 70% of the women are screened with a high precision test once at 35 and second at 45 years of age. 90% of women identify with the cervical disease receive treatment, care, and long-term follow-up. Updated WHO guideline recommends HPV DNA based screen and treat, screen, triage, and treatment approach, which is more appropriate to scale up the effective cervical cancer screening and treatment program. Thank you.
Today, we are going to talk on ensuring continuum of care in management of cervical cancer. What are the clinical signs? Typically, the cervix, when you put a speculum, it bleeds on touch. So these are the 4 common symptoms they will have. They will have abnormal bleeding, and most commonly postcoital bleeding. They have white discharge, particularly foul smelling, and sometimes blood stain. And then they have pain, deep pelvic pain, and lastly, cachexia. And the clinical signs are that when you put a speculum, the moment you put a speculum, they start bleeding. And when you do a PV examination, it is indurated, it is friable, bits of this tumor tissue come onto your speculum, and the tumor mass is fixed because of the infiltration. For a frank invasive lesion, a cervical biopsy is the most important investigation. This is how you stage the disease. On the left hand, the first picture shows a micro-invasive lesion where the basement membrane is intact. That way it's called stage 1A1 and 1A2, depending on the depth of invasion. And in the second picture, you have stage 1B, where the growth is obviously invasive, which you can see. It's macroscopic. And when it is less than 4 centimeters, you call it 1B1. And when it is more than 4 centimeters, you call 1B2. And the lower diagram, you see where the growth has extended down into the vagina, that is 2A, but not reached the lower third. And the right-hand picture on the lower side shows stage 2B, where it is extending laterally into the parametrium. So when the growth extends from the cervix onto the lower third of the vagina, it becomes 3A. And if it goes right into the parametrium, it becomes 3B. And when there's distant metastasis, like spread into the bladder and rectum, it becomes stage 4A. And when it goes into the distant parts of the body, then it becomes 4B. So what is the treatment? The main line of treatment will depend upon the stage of the disease. If it is stage 1A, 1B, and maybe 1B1, the treatment is mainly surgery where you do a radical hysterectomy. And what I mean by radical hysterectomy is I'm going to remove the whole of the uterus, the cervix with the growth, the parametrium, the ovary, the tubes, the whole of the parametrium and upper half or good cuff of vagina, and also the pelvic lymph nodes. That is radical hysterectomy, where I'm going to remove the tumor. Radiotherapy is the treatment of choice for all stages. Surgery is limited to only stage 1 and 2A. That's all early. So early cervical cancer, you can either do surgery or you can do radiotherapy. But later, for all stages, radiotherapy is the indication. There are 2 types. Radiotherapy can be given for all stages of the disease, stage 1 to stage 4. You can give radiotherapy, but it becomes curative in stage 1 and 2A probably. But beyond that, it becomes mostly palliative. Now, there are 2 types of radiotherapy which are given. One is called brachytherapy, where you put the radioactive sources in the cervix so that all the growth and the surrounding area is irradiated. And then you give what is called teletherapy, which is from the external irradiation, that is for the lymph nodes. So there are different methods giving radiotherapy, and nowadays radiotherapy has advanced so much that stage 1, when they give radiotherapy, the 5-year survival rate is as high as 98%. So the survival rates are much, much better with less morbidity with radiotherapy compared to surgery. As you know, surgery has got its own complications, but most of the patients feel that you should do surgery, take off the tumor as much as possible. Jhat se nikalna hai tumor ko. You should not leave back any tissue. So they are not really happy about radiotherapy per se, because the uterus remains there, the growth remains there. That's their feeling that it's still there. But actually, irradiation with modern radiotherapy, the survival rate is much better compared to surgery, because they give you a survival rate of almost 90%. Of course, a good surgery also early stages gives. So early stage of cervical cancer, whether it is surgery or whether it's radiotherapy, the 5-year survival rate is good enough. But the morbidity is much more with surgery compared to radiotherapy. So, but there are 2 types of radiotherapy, as I already mentioned, intracavitary and external. In radiotherapy, the vagina is not only shortened, but fibrosed and stenosed. So that is why we feel that to give a good quality of life, surgery should be done for younger women and radiotherapy for older women, because their marital life is not possible or difficult with radiotherapy because there's fibrosis and stenosis of the vagina. But in surgery, the vagina is shortened, but it is not fibrosed. And also in younger women, we can leave back the ovaries, so she will not have radiation menopause. If I give irradiation to a younger woman, then ovaries will be irradiated and she will have radiation menopause. So generally what we do is, for early cancers, younger women do surgery. Early cancer, older women give radiotherapy. Late cancers, like stage 3 and stage 4, you cannot do surgery. So radiotherapy is the treatment of choice. So surgery is the treatment for early cancers in young women. Radiotherapy is a choice for early cancers in older women. And remaining late cancers, always radiotherapy is the treatment, and mortality is almost comparable. Now, what is important with coping with cancer is that when a woman is diagnosed with cancer, there's a lot of emotional trauma. Most people think that cancer is the end. So these women require a lot of counseling by the family, by the family doctor, by the primary care doctor who has diagnosed them, and probably by the cancer counselors and GPs whom they frequently go to. And they think that life has come to an end. But usually that's not the case. If the early detection is the crux, early detection can give a normal life to this woman with a good quality of life, because they can't go on their own. They have to be taken regularly to the hospital, and then lots of financial burden, because these days cancer treatment is quite expensive. Of course, government hospitals are doing a lot of good work, but in every place there may not be a cancer institute, or there may not be a government hospital which treats cancer, which requires specialized treatment. So there's a lot of financial burden for these women. So those of us who come across these people who are not directly treating the cancer, we can give them a lot of emotional support by counseling them, lot of counseling for the family as a whole, because if they take care of her, she can live a long life and a healthy life with good quality. And also they might require some financial support, and the treatment also is prolonged, particularly if it's radiotherapy. It goes over a month or sometimes 2 months, because they have to undergo brachy and teletherapy. And many a time they have cystitis, proctitis, and they drain these people of their they lose confidence. These cancer patients lose confidence. So many of them have to be given a lot of courage and a lot of support, mental, physical, emotional, and financial support may be required for these cancer patients.
So let us start with the question answer. And the first question that I have is whether a highly sensitive or a highly specific test is better for population-based screening.
See, when you plan for the programmatic program, the test which you are implementing for the high prevalent area should be highly sensitive, because you want to pick up as many positive cases with one go. And in that, you say that in this basket, you have positive as well as the false positives also. But the negative group will be reassured, because they will not require the further treatment. So ideally, we require highly sensitive and highly specific tests, so that the screen positive cases, we can straight away give the treatment. At the same time, screen negative patients, we can reassure them. Currently, we don't have highly sensitive and highly specific test. If you see cytology, it is a highly specific test. But sensitivity is not there, hardly 50 to 70%. Because you say if the test is positive, then she has some lesion. But the test is negative, inflammatory smears, doesn't mean that she is not having the disease. There are 50% chances she may be having the disease. Whereas in case of HPV test positive, the negative, around 6 to 10% positive rate will be there. The rest of the 90% population can be reassured that they are screen negative. We can concentrate only on the positive. This is the idea.
Second question is whether once you give radiotherapy, does it affect the woman's fertility?
Yes. Yes, it affects the fertility. So there are people who sort of transposition the ovaries outside the pelvis, outside the field of radiation, and then they give radiation. Or they can also cryopreserve her eggs. That is a new technique.
Then there is another related question which also came about the HPV only, that we are all talking about cervical cancer. In that context, we are talking about the HPV testing, DNA testing. But in case men have HPV related cancer, do you think the same DNA test will work on them also, or not, or because we normally listen about it only for women?
Test is universal.
Yeah, it's the
can be
gender
used for
agnostic.
the gender.
Yeah, it is. It will look at the virus and not on the gender of the person who is doing it. One more question is, should we recommend two separate primary screening tests for high risk population and general population, or do you think the same one will be okay?
The single test is enough, but some of the Western countries, they do follow co-testing, HPV with cytology.
Which age group the vaccination can be taken?
9 to 14. 9 to 14, 2 doses actually with 6 months interval.
Interval.
The catch-up age is up to 26. So beyond that, you have to give 3 doses, 0, 2, and 6 months. After 26, it may or may not be helpful because we don't know. She may already be infected with HPV. So actually, after that age, screening is recommended rather than giving vaccination.
What is your recommendation regarding a single dose of HPV vaccine?
WHO has already recommended in low resource settings single dose for 9 to 14 years and 2 doses for 15 to 26 for low resource settings. That is what is the WHO SAGE recommendation. It has come up. And many studies do show that single dose is as effective as 2 doses for 9 to 14 years.
Is abstinence recommended before any screening test? If yes, for how many days?
In cytology, the abstinence is required.
2 days, 2 days.
Yeah, 2 days.
Whether there is any requirement for written consent before administration of HPV vaccine. Yes, consent is required, but in this instance,
Verbal consent is
girls are young girls. They are
Parents consent,
Yeah.
particularly 9 to 14, parents consent.
currently whatever method is available, screen with that method, the pap smear, HPV or VI. Do justice for whatever you are doing. And screen positive cases, don't just let them go. You have to follow them and treat them promptly. This is because this is how it should start from home and vaccinate your daughters, sisters, and among the family members.
Since I have been talking about invasive cancer, early diagnosis is important so that the treatment will be early diagnosis, complete treatment. That's most important. The quality of life is going to improve and she can, 5-year survival rate is also almost 98% with the modern surgical techniques as well as radiotherapy. So early diagnosis and complete treatment is the key factor for long-term survival of CS cervix. Even putting a speculum and seeing for any abnormal bleeding. Even just putting a speculum examination and visualizing the cervix and seeing whether it's normal or abnormal.
Cervical cancer is very unique because you can vaccinate, you can screen early, find the situation changing, and you can intervene at various levels. And I think that's where FPAIndia as an organization has an edge, because we do work with women across all the ages and going beyond the years of fertility. Very, very interesting and inspiring. We will come back to all of you again with a very smart and interesting episode of the Spotlight series. Bye-bye.
Thank you.